Good morning, everyone, and thanks for joining us today. I'm Anne Livingston, and I'm the chair of the Community Care Smart Assistive Technology Collaborative. I'm pleased to be the moderator for today's webinar. Today's webinar is titled New and Emerging Technologies Revolutionising Care and Support. Our webinar today is facilitated by Global Community Resourcing for the Community Care Smart Assistive Technology Collaborative. If you've joined previous webinars, you will know that they are designed from feedback and requests we receive through the Community Care Smart Assistive Technology Collaborative. Our focus of our webinars is to bring together local, national and international perspectives in research and development, as well as the deployment of smart assistive technology in the community care sector. Just a reminder that if you haven't formally registered at the collaborative site, this is accessible to all and free to register. Please register and visit the site as listed on their page there. Please note that Global Community Resourcing is not promoting or endorsing any particular product, research entity or organisation. Rather, the purpose of our webinars is to inform viewers of the various smart assistive technologies currently in deployment and or in development. In today's session, we welcome questions, but I will let you know that all your microphones have been muted. This is in the interest of our recording. Your questions can be added to the question panel on the dashboard on the right of your screen. There will be an opportunity for your questions to be answered at the end of the session. At previous sessions, we've been inundated with questions, so the earlier you post your questions, the more questions we can respond to. For those who have not used the GoToWebinar platform before, your control panel will be on the right of your screen. To change the placement of the control panel, drag the top of the panel or click the box button on the top right of the panel or the arrow. To ask a question or contribute to the chat, click chat and type your message. In today's webinar, it's my great honour to introduce Professor Greg Alexander. Professor Alexander will present on his research around new and emerging technologies that are set to revolutionise care and support. By way of introduction, Professor Greg Alexander is Associate Dean for Research and Professor at the Sinclair School of Nursing at the University of Missouri Health. Professor Alexander is an internationally renowned researcher whose research primarily focuses on trends in information technology adoption, quality and safety measures in aged care, and particularly their relationship between information technology, quality and safety measures. Welcome, Professor Alexander. I'll hand over the controls to you.
Thank you, Anne, and it's very nice to be here and nice to be presenting to you all. I am opening with just a slide about my credentials. I also have to give a shout out and some credit to the Fulbright Australian American Commission, who supported a 5-month stay in Australia, where I began to work with Anne and several people at Macquarie University to understand a little bit about the use of emerging technologies in long-term care in Australia, which has helped make my research more robust and helped me to understand a little bit more about your world and in comparison to ours. And I find that we have a lot in common. I will direct you to the www.eldertech.missouri.edu website. This is, if you Google ElderTech, it's usually the first site that appears on the US domain on Google, and all of our papers we have written in regards to the projects I'm going to talk about are there, as well as other resources, contact information, and things that you can use to inform your work. So I want to start out by just saying that my mission is to help keep older adults active and to keep them as highly functional as possible through the end of their life and as productive as I can through the end of their life. And my goal is to utilize technologies to help do that. This is actually a picture of my father. He passed away about 6 years ago in rural Missouri in the middle of the United States. And this is on his front porch, so you can see how rural it is. He got sick with cancer, and we kept him at home till the end of his life. And he lives about 3 hours away from where I do, so it was quite a commute. But we were able to keep him there, and because of the connections that we had with people that helped provide care, as well as being there for him because of some of the technologies that we were able to introduce. So he's part of my mission. And this is sort of an outline that I'm going to go over, squaring the life curve, talking about health changes using in-home sensors and fall detection devices and some of the systems that we use to help build the work and research that we do to help meet our mission. This is squaring the life curve is the way that we sort of look at how functional ability is affected by time. The red line is a current trend, actually without technology involved, and the green line is a line that would involve proactive care with technology. So this was published back in 2005, so a lot's happened in 13 years since we began to develop this. And I would say that this model is still a functional model for sort of a theoretical model around what happens to people over time. Without technology, people that want to live independently in the community back in 2005 did not have a great deal of connectivity that allowed them to be monitored at home or to allow them to really communicate with providers like we do today. So what would happen is when they had a change in condition or some condition that changed their functional ability, they would have a sharp decline in their ability to function. That could be activities of daily living, it could be toileting, it could actually be just basic care that they given to themselves. And once they did recover from that, they had a lower level of function. And this step was a steep decline that occurred till the end of their life. We believe that as technology was implemented, that we could intervene earlier because the technology would allow us to sense certain changes in conditions quicker, and then we would be able to intervene quicker, and they would have a better quality of life at the end of their life, which is represented by the green line. So we're going to talk a little bit about some of those technologies that we've been developing since 2005, such as Doppler radar, depth sensors, motion sensors, bed sensors, and I'll talk a little bit about each of these and the way that they've helped provide a way to monitor people in their homes. Then we have a decision support system that's has been created by our engineers who have taken what us as clinicians have provided them and helped them to create through our knowledge about changes in condition and how those alerts then can be utilized to inform nurses and social workers about the changes in conditions so that earlier interventions can be conducted. This is a place where we've done most of our research. We have a relationship with AmeriCare Corporation. They have a large sector of assisted living facilities in the United States. This one in particular was designed specifically for a project in the state of Missouri called Aging in Place. There were actually other demonstration projects for Aging in Place that took place early in the 2000 time frame. And we began to build a relationship with an assisted living facility who eventually built built this facility close to the university, and we have maintained a relationship with them. We have students from our university that go there and participate in the care of elderly people. We have a research lab there where people come freely, including people that live with our sensors. And as we develop those sensors, we would get feedback from people that lived with those sensors. So this was really implementation in a setting where sensors were being used and deployed at the same time that they were being developed, which is really important in sort of human-computer interaction principles and usability principles that are important for the development of technologies in clinical settings. You can see here sort of a description of the types of residents that were living that are living at Tiger Place. They're very representative of other types of people that live in assisted living facilities, so it's pretty generalizable population in relationship to their health and the types of chronic illnesses that they have. So we did some initial analysis to look at exactly how some of the sensors were impacting our residents. And we're not only talking about sensor systems, but we overlaid a very rigorous care coordination package that was available to the residents in this facility if they chose to utilize that. The care coordination package basically included the use of sensors as a way to monitor these residents in addition to regular follow-ups and those types of things. So what we did was we looked at Tiger Place residents without in-home sensors who just had the care coordination piece. So just with care coordination and really a strong nursing presence from nurses who have gerontological expertise, our residents would stay about 2.6 years, which was just almost a year longer than seniors in comparable U.S. housing. So there is some arguments there for aging in place just for coordination of care. But when you overlay residents that had care coordination and they had sensors also in their apartments, they stayed for 4.3 years, or nearly 2 times as long as those without sensors in Tiger Place. So you can see that that people live longer, and in our assessment had a better quality of life with these added years to their living, to the way they lived. These are the types of sensors that we used. So we used passive infrared motion sensors. We also used hydraulic bed sensors that actually are underneath the mattress. You'll notice all of these sensors are sensors that are not touching anyone. One of the original models that we decided to implement was that we would not utilize invasive types of technologies that people would wear. These would be non-wearable types of devices. So the bed sensor actually fits under the mattress, but it's very sensitive to pressure changes such as pulse and respiration. So we can actually capture pulse and respiration as a result of this hemodynamic monitoring. And then you can also see on the left lower side that image of a person standing there with what looks like a walker. There's one of our fall detection devices captured through using depth sensors, and I'll show you a little bit more as an example of that. This is an example of what we share with people who live in Tiger Place. We share these images with both residents and caregivers of residents that may be living in places far away from the actual resident themselves. So for example, we have some family members that have residents living in Tiger Place, but the caregivers are a long ways away, like Colorado, which is 2 states away. And they actually want to understand the configuration of how these sensors work. And so we created this sort of mapping of where sensors are, where our gate sensors are, which is shown by the red arrows, lines there. And so it gives them a sense of the types of sensors that are there, where they're placed, what kinds of activities we can monitor. You can see up in the upper right-hand corner, just below the 11 by 8 by 13 diagram, that there's a bed there, and there's a bed sensor affiliated with that image. And you can see the number of types that we have. So this was informative for people to help them understand exactly what we were trying to do, and help them to understand the placement in their apartments. This is another one of our research subjects. This is Eva. Eva had a long history of congestive heart failures, and we were on a mission to keep Eva out of the hospital and to try to keep her at home as long as possible. And Eva's one of those people that came in and out of our research projects, and she was involved with our sensor development from the very beginning, and she was fun and energetic. And so we try to keep these pictures as part of our ongoing discussion, because they really shaped what we've developed. And they were some of our first people to really help us with the emergence of these types of devices, and their input was absolutely critical. So we really try to keep their presence alive as we move forward. And Eva has died since this picture was taken several years ago, and so it's sort of a tribute to them. This is a picture of our sensor network for you techie kind of people. You'll see from the far left that it starts out with our sensors, including bed sensors, gate sensors, motion sensors. So there's a duplicity of different types of sensors that feed into this sensor data system that are all integrated into these alerts, and to help us to detect change in functional status and decline. And then it's fed through a web portal and an interface that allows for us to provide health change alerts to an email address that a clinical care coordinator can access and look at. And while I was in Australia, while I've been in Australia, I've received a lot of these alerts while I was there, because we don't turn them off. We keep them going, and we keep looking at them. So I can actually be around the world and assess a person's change in condition, and can notify them of what I'm seeing, so that somebody actually can go and take care of them and see how they're doing, which is a huge change from what we used to be able to do without technology in the community. This is an example of the health alerts that I received. This is from the very beginning of March. This was a beginning, an alert that we received at the beginning of March, and you can see that's very simple interface with a link to a data on an interface. So this is an exact replica of a message that I received in my email. You can see that it expires in 29 days if you looked at all the detail of this image. So it doesn't stay in your email for very long, but it is 29 days of time to look at. And sometimes you get quite a few of these alerts coming across your system, which is something to be monitored for workflow for a nurse. So when you click on that link, you get this sort of an interface. This is not a dynamic interface. I took a picture of what that alert was about, and you'll see here that this alert was actually a gate alert that said that this person on Friday, March 8th, appeared to have a walking speed decrease, and it gives a little bit of information. So we've been working with trying to create these linguistic summarizations out of the data that is utilized and shown on the screen, because people that are clinicians can tend to read and know what this language is as long as it relates to the data. They may be able to figure it out a little bit better than some of the visualization techniques we have. So we've been working a lot with this, and you can see that this one in particular says that during the current 7-day period ending March 8th, that the walking speed is 9.4% lower than the average walking speed for the previous 7 days. So what we do is we have sort of a sliding window of 14 days that the person's gait is measured against their own typical baseline. So we're measuring changes in their gait speed according to their own baseline, which is a better measure than if you were measuring it against the average of several hundreds or thousands of patients. It's actually looking at their own gait. But we've based these estimates really and our alerts off of evidence-based practice and what changes look like. But we're utilizing their own baselines to help us understand that. And you'll see at the same time, just a couple of months earlier, this person had another alert that related to percent of time in bed and that it was increasing. So combined with a gait change that indicates that their average walking speed is lowering and they're spending more time in bed, that could be an ominous sign. That could mean that there's a change in condition that we would want to check on. This is an example of one of the graphs that I was telling you about. So this previous one is a health alert, and this is the actual data that is behind that health alert. So this is March 8th on the right-hand side. So this as actually, if you'll help me or let me explain this just a little bit, each of these columns going from top to bottom is a day. So you can see January 31st, February 3rd, February 6th. Those are individual days in each individual column going up and down. And as you go right and left on this graph here, you'll see that it's a 24-hour period each hour in the day. So basically what you have is a 24/7 view of activity in this person's apartment. Looking at the density map on the far right, you'll see that the top part of the density map is a dark or a sharp royal blue, moving down to greens and yellows and then grays and black. The blacks indicate out of an apartment. We have an algorithm that the engineers have helped us develop with a lot of testing that we can be assured that a person, when they're leaving the apartment and when they're in the apartment. And what you'll notice here is that this person had a lot of black prior to March 8th, especially in this period between March 5th, 6th, and 7th. They had a lot of black, some high level blues and a lot of yellows. But if you notice on those last 2 days, March 8th and March 9th, that they had more grays, less blacks, and more yellows, which means that they were not going out of their apartment nearly as much as what they were in the previous few days. And also they're having less activity when they're in the apartment. So this combined with the activity decrease and the gait speed decrease might be something, and the increased time in bed might be something that we would want to be alerted to. And you can see this red box here indicates when the alert was received. This is an example of, this was an older example. I like this one. Sometimes we pull these use cases out because they're very informative. You can see we've published these use cases because they really represent exactly how we think that this system should work. So again, you have these density maps here where you've got 24/7 days throughout a period of time. So this is the several days between August 18th and September 18th of 2009. And you can see 24/7 what happened between that period, which was just about a month. And then you can look March to April, which is another month in 2010, but this was about maybe 6 months later. And then you'll see October 1st to October 31st, which is another month, which is about 6 months later. So these are 18 months with 6 month snapshots. And what you see here is on the first block under August 18th to September 18th, you see there's a regular pattern of black around 7 a.m. where this person was leaving the apartment. They would go out at lunchtime. They would go out at dinner time. They had typically activity up until about 11 p.m. when they would go to bed. There was no activity at night during 12 to 7, which you really wouldn't expect to see too much activity there. So all in all, a pretty regular period of time and with some activity in the apartment. If you look at the second block, you'll see this is the same person's activity over the same period of time of about a month. And you can see that they are going out of their apartment less often, and very, very rarely going out at lunchtime or dinner time. And these individuals do have kitchens in their apartment, but oftentimes they eat out in the dining area with other people. And so, this person's socialization was seemingly, they weren't going out to socialize like they were. It was a pretty significant change. And you'll notice that there was a lot more yellows during this period of time. And also, if you'll notice in the nighttime, there's some gray boxes, which indicate that they were actually up at night more often at periods of time that were sort of unusual. And then if you notice the third box, they're back to their regular pattern. And however, they're even more active, it appears to me like. Going out just nearly as much, but they're even more active. So when you put the underlying clinical record with this, what you know about this person is that they had depression that was managed by a geriatric psychiatrist in the first block, but they were pretty well managed, or at least had a pretty regular lifestyle. In the second block, they had, during this period of time between September and March, had experienced a personal loss and had experienced low energy and trouble eating and stopped going to the dining room. And this was all documented by a care coordinator. And in the third block, you'll see that the geriatric psychiatrist had conducted an intervention that helped improve the resident's activity level and manage the depression better. So it's another use case of exactly how technology can inform us, whereas you might not have seen that without that technology or care coordination access to that information. This is an example of an interface evaluation that we used with 20 end users. These types of activities are very important. This is an early snapshot of our interface where we used a lot of histograms, but we moved from this to our density maps because of these actual interviews where people told us how they would use the system, how they viewed the system. And so we basically showed them data, we gave them some scenarios, and then we had them work through the scenarios looking at specific information, and we recorded these. And you can see that's me up there with one of our nurses who worked at Tiger Place, who gave us some feedback about this interface, and we made adaptations as a result. These are the types of scenarios that we used. We used an emergency room visit, so a person in the facility that lived with sensors that had an emergency room visit that was cardiac related, a hospitalization, and also a person who passed away. And what we did was we asked them to look at the sensor data to help see if they saw any patterns around these events that could occur, such as a slow pulse rate. We also had them look at activity to see if they thought any activity was decreasing. We also asked them to see exactly, to see if they could conceptualize sort of this event and see if the information was useful if this type of event would have happened to one of their loved ones. And what we found was a lot of people conceptualize the data exactly like we thought they should. So residents and family members had these types of comments, and I'm not going to read them directly to you, but they basically were conceptualizing the data in a way that we had set it up to be conceptualized, which was a good thing. They looked for things like, did they spend more time in bed? And if they were spending more time in bed, then they would be concerned that somebody wasn't feeling well enough to get up, exactly like we thought the sensor system should work. So it sort of validated what we had thought we were developing. Bed restlessness, this was an early version of our bed restlessness mat, where they equated where someone who has been restless at night before they fall asleep, but then fell asleep, there was a change perhaps there. Restlessness is a type of activity that's not been measured very much. So sensors allow you to develop a new sort of way to assess people and look at their pattern of behavior a little bit differently. And a lot of these statements go along to help us to understand that those new ways of looking at things really do make sense. Nurses and physicians also had different sort of views. For example, they looked at respiration, and they looked at the number of breaths per minute that we had recording on our restlessness map. And they said 6 breaths a minute would expect a person to have high restlessness. So they were trying to equate what was actually happening with the vital signs that we were collecting with the restlessness, which was a new measure. Bad breathing shows periods of apnea, which are concerning that may indicate pneumonia. So they were looking at diagnostic sort of outcomes as a relationship to the changes in what they saw in the condition of a patient over time. And so many of these things relate to those types of things. It's exactly like what we wanted to see and how they problem solved utilizing these things. So these are the types of health changes that they felt like sensor systems would really be important in early detection, such as urinary tract infections, pneumonia, CHF, post-hospitalization pain that was not managed well, delirium and wandering, low blood sugar, hypoglycemia might be. So these were types of things that we sort of began to look for cases around. This is another example of a bed sensor that we built as a team with clinicians and engineers working together. This is a hydraulic mat, so it's filled with 4 chambers filled with fluid now, and those fluid chambers are connected to a sensor that's very sensitive to pressure changes. So, and this is a ballistic cardiogram tracing. So a ballistic cardiogram is a type of pressure-sensitive device that's measured that can be compared to an EKG. So this is an ECG. This is a typical heart rate pattern that is worn, that is found when you put a ECG on a person with the leads and the different types of things that you see people putting on people's chests to get their heart rate. And this is a BCG, ballistic cardiogram, completely different waveform, but these waveforms can actually be laid over the ECG to show that when these pressure changes occur in the ECG, when the contractility occurs in the heart, there are pressure changes in fluid that go down from your heart to your extremities, and those can be detected as well. So what we did was we tried to look at those overlaid with each other to see how valid it was to use the ballistic cardiogram as a way to measure pulse and perhaps blood pressure and respirations over time. And what you see here is the ballistic cardiogram at the top with the systolic pressure change with those little dots showing the highest area where the systolic change occurred, overlaid with the ECG. And you see that they line up pretty well with the ventricular contraction and the pressure changes. And then when you overlay the bed sensor with a finger sensor, like a pulse oximeter that measures oxygen and pulse rate, there's a very good agreement between the finger sensor and the bed sensor. So there are really good agreement between when there is a pulse and a pressure change, starting from where a person is laying and having their EKG read all the way down to the finger sensor device. So there was a pretty reliable way of measuring blood pressure and pulse and respiration, and sending an alert to a person if they were having a problem. So this is capturing gait using an in-home sensor, and you can sort of see there that that pattern of movement there. One of the things that we tried very hard to do was to try to keep people's identity private. So we worked with our engineers to try to strip out all the background information. We just wanted to be able to see what their gait was and what their fall risk was in relationship to their ambulation. And so we began to look at how to strip out that background information. You can see 3 different types of looks here. And this has evolved over time, and many there's many publications in regards to this that you can read about that will help you understand how we did this. And also, one of the things that was very important to us was to validate this system. And so the Vicon system, which is this green dot at the top, the red dot is a connect, and the blue dot is a connect. These are two different types of systems that allow you to detect movement. Connects are gaming devices. We use the advantage of the gaming device to help us with the Vicon to help us understand what patterns of walking were. And so the Vicon is shown here on this person on the left, which is a physical therapist, she's wearing all the different patches part of the Vicon. That's not feasible for having people wear in the community. So what this Connect does is it connects to the wall and it captures movement as people move through the apartment. So we put each of those in an apartment and had people move across those apartments, and we looked at walking speed, stride time, and stride length, and you can see that there's really good agreement there and validity and reliability in relationship to using these Connect devices as a gold standard compared to Vicon. So when we look at these in relationship to movement, we not only are concerned about people who live alone, but we also have interest in people that have a person that they're living with, a partner. And so in this case, what we did was we used height as the x-axis, and we used speed of walking using the Connect to capture motion in the apartment. And you can see that there's two different levels of walking captured here based on height and speed. And so we looked at these and this was very hard to interpret, but we knew that we could capture the gait and speed of two different people who live together based on their height and their speed. So what we did was we mapped these to a different graph where we looked at each day along the x-axis, and we look at their height and their different measurements along these other axes, so that you could look at height across the daytime. You could look at stride time, which is the green, speed, walking speed is the red, and the blue is walks per day, and the purple is stride time, which are all measures that are really not easy to measure. These are much more precise measures than what we have had in the past. Technology allows us to be very specific about these types of things. And what you have here is a healthy husband and his wife with Parkinson's. So what you might suspect is that if a person came in without technology, they might focus completely on this person with Parkinson's and not on the healthy husband. And what we find out that really the person that's having the changes with the gait sensors is that the person, the husband, that's the healthy husband, supposedly is actually having the decrease in walking speed and decrease in stride length that could be brought on by the increased stress of dealing with his wife with Parkinson's, and she's fairly stable over time versus his changes. So this might direct us in a different direction in assessment and looking at these people and how they're coping with the illness that's going on inside their apartment. And the technology is really informing us about things that are different. When we look at in-home gait changes and looking at fall prediction, this is an article we published in 2016 in the Western Journal of Nursing Research. You'll see that a decrease in walking speed of 5.1 centimeters per second, which is not very much of a change, over 7 days actually gives an 86% probability of falling within the next 3 weeks. So we looked at number of changes in walking speed over time and a number of patients who had fallen, and those people who had fallen actually had that amount of decrease in their walking speed. A decrease in stride length of 7.6 centimeters over 7 days. It was about a little over 50% probability of falling. So these things can be used as predictors to help us build a good decision support system that we can go and provide some treatment to people perhaps before they fall. So we looked at the in-home sensors to detect health changes before any person could do without technology, and the sensors helped us do that. And what it did was to also help us to detect falls. And so This is another alert that I received. This one was received on March 9th at 2:50, and I was in Australia during this period when I received this. And what I could do was to click on this residence link. And what it does is it takes you to an image that allows you to see exactly what happened. And here in this first image, you can see that this person fell. Their cat actually was sitting on the couch. You can see there's a wheelchair there. You can't see anything to identify who this resident is. You just can identify that she fell. This is a different image of a different resident falling. You can see one thing that's very helpful in these images is that you can see exactly how they fell. Did they hit their head? And this one specifically, I'll play over. This one, the chair was obstructing view, so you can't really tell that she hit her head, but you can tell that she fell backwards and landed on her sacrum. And so you might be concerned about how she was injured there compared to other types of pictures. So before, we didn't know how people fell. We just know they fell and that they were laying there. This way, we know that through the sensors, we know when they fell, how long they've been laying there, and that we can actually get there in a pretty fair amount of time once the alert's received. Here's an example of a fall alert that is not related to a fall. So we worry about false alarms. So I'm going to show this one more time so you can look at it. This person has an animal that jumped off, and this was actually a false alarm. So the person is sitting in the chair, but the animal was detected as a fall. This is a different type of an issue. These types of issues are related to people cleaning up and throwing things on the floor, and this image was shown as a fall. So we can make sure that these images, we can change the sensitivity to these fall sorts of activities, and we did that. We played around with this threshold over several days where we looked at fall detections. And what we've done is with a lower threshold, we find that we detect more falls. So at an 18% threshold, we have 15 people on the floor, 18 objects on the floor, 12 pets, and 21 others. So we have 66 different types of falls with a 4.0 falls per month as an average. And when you increase the threshold so that you're not detecting as many falls, you'll see that there's 4 people on the floor, 0 pets. So you've sort of taken out that factor. You might have a few that have objects on the floor, and you have 9 total, so 2.4 falls per month. So you have to decide at some point what the benefit and advantages of having these thresholds and what the threshold would be. And this would be an organizational sort of thing that they could tweak and work with to help them, decide based on the patient's risk what sort of threshold they might want to have. And these are the types of false alarms that we looked at over 10,000 days, looking at false alarms, what types of false alarms there were, and how many falls per month per person there were that were based on false alarms. And that's been published a couple of years ago, so you can look at those. It's all about validity and reliability and workload, actually, of the individuals who have to respond to these alarms. So this takes a lot of people, and I want to point out a couple of people here. This is Marilyn Rance up here with this first blue square around her. She's one of the PIs on this grant. Marge Skubik is right here, if you can see my cursor, right in the middle of the screen on the top. Those 2 people are the PIs. They're computer science and nursing people, and then these other supportive casts are interdisciplinary people from all over the campus. And Foresight Healthcare is our company that has been created and that is now taken on the business side of things while we are doing more research and trying to develop tools to better keep people home and safe. And this is finally Marge's parents who were living in North Dakota, which was a several-hour flight from where we live. Here in central Missouri. They were in their late 90s when this picture was taken. They are now expired, but they were living with sensors for years before, and Marge would actually keep track of their health and wellness while she was working as part of the research team, and was part of that early detection system when they had a decline. But you can see they had a pretty productive life at the end of their life, and so we try to keep them going as well. So I'm open for questions and answers, and I thank you for your time.
Thanks very much, Professor Alexander. That was a great informative presentation today. We've got questions filling up our question pane, but unfortunately we're probably only going to have the opportunity to answer 3 of those. By way of the first questions from Nathan, Nathan's very interested in the policy drivers for greater uptake of technology in care provision, Professor. And Nathan asks, could you give some insights from your experience about what policy and funding settings work best to promote the greater use of technology?
Well, yeah, there are several. The first that I would say is that for trying to reduce, trying to shift care from the most expensive care in hospitals and acute care areas to community settings requires a different sort of payment models and of course new tools to be able to monitor and to grow different kinds of ways of keeping people in their homes and keeping them safe. And so different kinds of funding agencies will fund development of technologies, and then other agencies that support clinical care will support the implementation of those tools and technologies, which are typically developed by engineers with the support of clinicians, and the clinicians will take it and experiment with them in an actual clinical setting or a lab setting to determine their effectiveness. And essentially what you try to do is you try to show that you can detect the changes in conditions earlier and prevent the hospitalization so that you can get somebody in there earlier and keep people healthier longer toward the end of their life, so that you actually reduce costs of care associated with a transition to a hospital, and keeping people at home where they want to be longer with a supportive cast of people around them that can keep them there, including good care coordination.
Thank you, Professor. My next question is from Brooke. Brooke's a workforce development consultant, and she is interested at any comments you have around the level of workforce development that's gone into your projects.
Yeah, so workforce development is a major issue. One, because typically in community settings like assisted living or places in the community, there have not been good development of IT departments. So oftentimes the IT functionality is contracted out in most of these settings to people who know about technology, but they're not part of that organization, so they don't have that same vested interest in the development and implementation of that technology other than just through that contractual arrangement. So what you end up happening is you end up having people in those facilities or even in the home who are managing technology who have not been trained to do so. And so if the system goes down, oftentimes you have people managing, trying to implement upgrades or doing things to the system that maybe they don't completely understand, and they're being guided by somebody who's part of a contractual relationship in order to do that and get the system up and running. So there are major workforce issues to try to get solid, knowledgeable people who have solid backgrounds in IT systems implemented, or to become partners with these settings so that these systems can function. Also, I think there's an issue around the rural locations. So we know that there's a difference between rural settings and urban settings and their level of connectivity and functionality. And there's just a need for infrastructure, and the infrastructure takes knowledgeable people to be able to implement that. And so you get into issues of managing systems in those areas too that need our attention.
Terrific. Thank you, Professor. Our last question is from Georgie. Georgie comments, as you're aware, Professor, that Australia is currently having a Royal Commission into the quality of aged care. What lessons, she asked, what lessons you might give our country as it spotlights how innovation and technology might improve the quality of care?
Well, having toured around Australia and visiting a lot of organizations that are very interested in keeping people in the community, I think the initiatives in Australia are very similar to those in the United States. We have the same goals, and we can learn from one another about how these systems work best and under what circumstances, so that we're not duplicating efforts. And I think that we all have the same goals in mind, is to try to reduce costs, improve quality of care of these residents at the end of their life, allow them to have a choice in their care that they receive in a location that they want to receive it. And in order to do that with our current workforce and the number of people that we have in long-term care settings, we need to make it attractive for people to want to come and work there. And I think that technology can do that in a tech-savvy world that we live in. It's appealing to the younger generation to work with technology, and to work with older people with technology could create a better environment, both for the patient and for the worker. And so I think those are good goals to try to achieve, as well as safety. I think safety is critical, and I think by showing you some of these images and some of this designs of the technology that our teams have developed, that we really can improve safety of an individual who's living in the community on their own, and provide better care.
Thank you, Professor. That's all that we've got time for in terms of questions today. I'd like to thank you, though, for your comments and your presentation today, Professor. It's been really informative, and I know builds on the work that you've done here on your Fulbright Scholar placement, and the work that we hope will continue in this country with your expertise. So thank you very much.
Thank you so much for having me.
So just in conclusion, what's next for our Community Care Smart Assistive Technology Collaborative? Many of you would know that we've been doing some work internationally about living and aging well on island communities. We're going to bring some of that research work and project work together in an event on an island in Queensland. So if you're available in May, we'll be holding a session in Macleay Island off Redlands, looking at the role that innovation and technology could play in better supporting island communities. Please get in touch if you've got any further questions or comments with the project team, and on your slide here you'll see the contact for the project team. Just again, if you haven't already done so, go online and register with our collaborative. You can access today's presentation and have the opportunity to ask further questions. Once again, I'd like to thank members of the collaborative research team, in particular Georgie Gould, who's put together today's webinar. And I'd particularly like to thank today's special guest, internationally renowned Professor Greg Alexander. Thank you again, Professor Alexander, and thank you everyone for attending today's session.